All right, today we are jumping into a topic that's incredibly important, but often, honestly, a little misunderstood. We're talking about male infertility and what the evaluation process actually looks like, from start to finish. So, let's start with a number, 15%. According to the World Health Organization, that's how many couples worldwide are affected by infertility. We're talking nearly 1 in 6. So this isn't some rare issue, it's a major health concern for millions of people. You know, for the longest time, whenever a couple was struggling with this, all the attention, medically, socially, you name it, tended to focus on just one person. But, as we now know, the science tells a very, very different story.
And this chart, well, it completely resets our whole perspective. The data is clear. The contribution to infertility is split right down the middle, about 50-50, between male and female factors. And that's exactly why a really thorough, really thoughtful evaluation of the male partner isn't just a good idea, it is absolutely essential.
Which brings us to our first big idea here, what we can call infertility's hidden half. We're going to really focus on the male side of things, which for way too long has been the less discussed and often overlooked part of the fertility journey. This quote just nails it. Reproductive health is an unusual aspect of medicine. 2 patients are required for a positive outcome. I mean, think about it. For almost any other condition, you're treating one person. Here, success literally depends on a unique biological partnership.
So, how does this partnership really play out month to month? Honestly, the best way to think about it is like rolling a die. Even when everything is perfectly aligned, conception is never a guarantee. It's a game of chance. In fact, one big study showed that even for couples who did get pregnant, only about 42% managed it in the very first month. It's all about probability.
And this number, 35, plays a huge role in that probability equation. It's the age when, on average, female fertility starts to decline more quickly. This really highlights why it's so important to evaluate both partners at the same time. You want to make the most of every opportunity.
So, with all that in mind, how does a doctor even start to piece this puzzle together? Well, that brings us to Section 2, your story. It all begins with a detailed history, and there's a fantastic little mnemonic that helps keep it all organized. It's called TICS.
So where do they start? It's kind of like detective work. The doctor starts by asking a whole bunch of questions, just looking for clues in a patient's past that could be affecting what's happening right now. It's a very methodical investigation.
And the framework for that investigation is the TICS mnemonic. It's a simple but really powerful tool, kind of like a mental checklist to make sure nothing important gets missed. So let's break down what each of those letters actually stands for.
First up, T is for toxins. And wow, this covers a lot of ground. We're talking about recreational stuff for sure, but also prescribed medications. Here's one that catches a lot of guys off guard. Taking external testosterone can actually shut down your body's own sperm factory. Then there's environmental stuff like pesticides or even just the heat from having a laptop on your lap too much.
Next is I for infections and inflammation. Basically, has your body fought a big battle at some point? Getting mumps after puberty, for example, can sometimes cause inflammation in the testes. STIs can create scarring and blockages. Even things like prostatitis and inflammation of the prostate can play a role.
The C goes way back. It stands for childhood conditions. Stuff that happened when you were a kid can have an impact decades down the line. A big one is undescended testicles, or something called testis torsion. That's a twisting of the spermatic cord that's a medical emergency. Even a common childhood surgery like a hernia repair can sometimes affect things.
And finally, S is for sexual history. This is really about the practical, mechanical side of things. You know, are the timing and frequency of intercourse lined up right? Could a certain type of lubricant actually be harmful to sperm? Are there any issues with erectile or ejaculatory function? All of these are really crucial pieces of the puzzle.
Okay, so once the doctor has heard your whole story, the next step is the physical exam. This is where they can look for actual, tangible clues that can add to everything they've just learned.
And one of the most important things they're looking for is something called a varicocele. It's basically just a bundle of varicose veins in the scrotum. The analogy is perfect. It's just like a varicose vein you might see on someone's leg, just in a different spot. And it's surprisingly common.
So why is finding one such a big deal? Well, here's the key. A varicocele is the single most common surgically fixable condition that's found during these evaluations. Identifying it is a huge step because it's something that can potentially be treated.
And now, we get to the part everyone immediately thinks about when they hear fertility testing, right? The lab work. Section 4 is all about decoding the semen analysis, but it's probably not as cut and dry as you might think.
Okay, this is where it gets really interesting. The source material, we're talking a major urology textbook, makes this pretty shocking statement. It says that the semen analysis, the primary test for this, is actually a poor predictor of fertility.
Which of course leads to the obvious question, right? If it's a poor predictor, then why on earth is it the cornerstone of the whole evaluation? And the answer is that while it can't stamp you as fertile or infertile, it gives a vital snapshot. It's a baseline that helps guide the rest of the investigation.
So, let's look at what they're actually measuring. We've got concentration, how many sperm there are, motility, how well they swim, and normal forms, their shape. But the most important thing to get here is that these are not pass-fail scores. That lower reference number, that's the 5th percentile of men who successfully had a baby within a year. It's a reference point, not a verdict.
And when you get a report back, you might see some pretty intimidating medical terms, right? Like asthenospermia. All that means is reduced sperm motility, so fewer sperm are swimming forward the way they should. It's just part of the language doctors use to describe what they're seeing.
So, we've got the story from the TICS interview, we've got the clues from the physical exam, and now we have this baseline data from the semen analysis. So our final section is all about putting it together, going from just having numbers on a page to having real knowledge.
Because this whole evaluation, it's a journey. It's all about connecting the dots, not getting fixated on one single number. It starts with understanding the big picture, the probabilities. Then it moves to telling your complete story, finding those physical clues, and using that lab test as a guide, as a starting point, not as the final word.
And that really brings us to the most important point of all. The goal of this entire process isn't just to end up with a number on a piece of paper. The goal is to find a path forward. So when you have a story this complex, involving your life history, a physical exam, and tests that aren't perfect, you have to ask, what does the next chapter hold? What's coming next to make this diagnosis even better? And that question is exactly what's driving the science forward every single day.